Today I'll be talking about hysterosalpingography. It will be a very short class about HSG and what are the various uses of HSG. So hysterosalpingography is nothing but a procedure in which the contrast is injected into the uterus to study the uterine cavity along with the fallopian tubes. Okay, so the uterine cavity and the fallopian tubes are studied in a HSG, and the indications are infertility, recurrent abortions, following tubal surgeries, migrated IUCDs, uterine and tubal lesions like tuberculosis, submucosal fibroids, polyps, and synechias. So these are the indications. So it is mainly done in females who are very infertile, or during secondary infertility also it is done, or even following tubal surgeries, that is following sterilization. If there is failed sterilization also, sometimes it is used. And in chronic infectious cases like tuberculosis also, to find if there are any submucosal fibroids or any synechias which are present within the uterine cavity, HSG is done in such individuals. So what are the contraindications? If there is sepsis, that is if there is infection, then you shouldn't pass contrast into the uterus. And sensitivity to the contrast media, because we use ionic contrast media. And decent dilatation and curettage of the patient if it is done recently, because raw areas of mucus will be exposed to the contrast. If the patient is pregnant, because the fetus will be exposed to X-ray radiations the week prior to and the week following onset of menstruation, because when there is ovulation, there is a chance that the female might get pregnant. So during this time period, we avoid doing HSG. And in cases of severe renal or cardiac diseases, it is avoided because of the contrast, which is a high osmolar contrast media, and cervicitis or puerine vaginal discharge, which is again in case of infections. So what are the equipments of what we use for HSG? Firstly, talking about the contrast media, we use a water soluble contrast media, for example urographin. Okay, 10 to 20 ml is used. Okay, and we need a syringe for injecting the contrast media into the uterine cavity. Then we need a cannula. In this case, we use a Leach-Wilkinson cannula, and then we need a uterine sound and dilator so that we can dilate the cervix. Then insert the Leach-Wilkinson cannula, and then through it we can inject the contrast media. Okay, we need a Sim speculum for separating the lips, anterior and posterior lips of vagina, the tenaculum. The trauma is less if we use a tenaculum, so it is ideal for nulliparous women if indicated. Fluoroscopy unit with spot film devices are needed. Okay, so this is the Leach-Wilkinson cannula, which you can see in this image. This is the tenaculum, which causes less trauma in the individuals. These are the Higgins dilator, which dilates the cervix. And this is the speculum, which you can see, and this is a sponge holder. So what is a procedure in which an HSG is done? Is the ideal time for procedures between the 8th and 10th day of menstrual cycle, that is 2 to 3 days after stoppage of menstruation is ideal for doing it. It is done before the 12th day because the oocyte undergoes meiosis during this time and it's radio sensitive. Okay, so thus radiation exposure during this time should be avoided, because if there is radiation exposure during this time period, if the female conceives during that ovulatory cycle, then the fetus will be affected. Then what are the patient preparation which is needed during the process of HSG? Is the patient should be advised to abstain from intercourse between the booking and the appointment and the time of the examination. The patient should be fasting for 4 hours prior to the procedure. Then what is the pre-medication which is needed for the patient? It is not required in majority of the cases. When the patient is very anxious, 5 to 10 mg of IV diazepam is given of the patient, which acts like an anti-anxiolytic 13 minutes before the procedure, and it is helpful to prevent tubal spasm, because in cases of anxiety or the patient is very nervous, it itself will cause tubal spasm. It can give a false positive report in cases of HSG. So in very anxious cases, we give 5 to 10 mg of IV diazepam. Morphine and pethidine should not be given as they stimulate the contraction of the fallopian tubes. The bladder should be emptied prior to the HSG procedure. So what is the technique in which we are going to do this procedure? We are going to use a cannula. The patient is placed in lithotomy position. A speculum is introduced into the vagina, and anterior lip of the cervix is held with the tenaculum. So the anterior posterior lips of the cervix have to be separated by using a tenaculum. A speculum is introduced into the vagina and general traction is applied. Then a cannula, that is a leech Wilkinson cannula, is inserted into the cervical canal under direct vision. The speculum is then removed in place, and just a cannula is there in place, and the patient is carefully moved up the Xray table, because when this procedure is done, the patient is placed a little down the Xray table. So for proper positioning, after the cannula is put in place, the patient is put out in proper positioning in the Xray table. And under fluoroscopic control, first 2 ml of the contrast media is injected to outline the uterine cavity. The injection is then continued slowly, governed by the patient's tolerance, until the oviducts have been outlined and free interperitoneal spill of the dye is visualized. Then how is the filming done? As the tubes begin to fill, when peritoneal spill has occurred, maximum X-ray screening time must not exceed 30 seconds using an image intensifier, and only 2 X-ray plate procedures are permitted in order to minimize the radiation to female gonads. So we are using X-ray. X-ray is a harmful ionizing radiation, so we should use it as minimalistic as possible. So since the female gonads are directly exposed to radiation in the case of HSG, we are just going to use maximum of 2 X-ray plate exposures are only used in case of an HSG with a kV range of 70 to 90. Okay, so this is how a normal hysterosalpingogram looks like. Okay, this is the leech Wilkinson cannula. By injecting a syringe into it, a contrast media is pushed into the uterine cavity. Here we can see that the body of the fundus of the cervix is completely delineated with the contrast media with the 2 fallopian tubes, and this is a free intraperitoneal spill which can be properly visualized in case of a normal HSG. Okay, so first what you have to see examples. Okay, this is an example of the normal tubal patency, which is seen in this case with a free intraperitoneal spill, and this is a case where a partial filling defect is seen in the body of the uterus. Okay, when the contrast media is injected, this is a case of endometrial polyp which is present in another case. Okay, so here again there is a filling defect which is present laterally in the body of the uterus, which is an example of submucosal leiomyomata. Okay, and in this case you can see that there is completely irregular filling of the body of the uterus, which is mainly due to synechiae. Now this synechiae can be due to many other causes. It can be because of previous procedures which have caused, or because of chronic infections such as tuberculosis, which has resulted in formation of the synechiae and complete or partial filling defects in the body of the uterus, as seen in this case. Okay. Here in the cases of tubal ligation, you can see only some part of the tubes are visualized, and there is no free intraperitoneal spillage as in normal HSG cases. So there is a cutoff of the contrast material in the isthmic portion of both the fallopian tubes with bulbous dilatation. Okay, so of the distal aspects of the opacified portions. These findings can be seen with post-surgical occlusion or following tubal ligations. Okay, then HSG can also be done using a Foliage catheter. The cervix is exposed with a vaginal speculum and swabbed with an antiseptic solution with the patient in a lithotomy position. After the lumen of the catheter is filled with contrast, and catheter is inserted through the cervical os. When the balloon lies within the uterine cavity, it is generally inflated with water. Okay, before the injection of contrast, the balloon is pulled downwards against the internal os. The speculum is withdrawn and the catheter is attached to the syringe. The patient assumes a more relaxed supine position. Contrast injection and filming is done using a cannula. More than a Foliage, we feel more comfortable using a leech Wilkinson cannula, so we use more of that procedure and less using the Foliage catheter. Now, what are the advantages in this Foliage by using Foliage catheter? Is that we don't need a tenaculum, that is we don't need a tenaculum for separating the anterior lip of the cervix. Thus avoids possible cervical trauma, and bleeding can be avoided. Then ability of a single operator to control both the injection and exposure of spot films on the conventional fluoroscopic machine can be done. It is much easier to obtain the radiographs in this procedure. A drainage radiograph can be obtained at the end of the procedure to demonstrate the uterine cavity without catheter creating artifacts. It can avoid the formation of false passages, and it avoids potential uterine perforations. So what are the disadvantages? Is the tip of the catheter sometimes blocks one side of the tube. Okay, the part of the uterus adjacent to the bulb cannot be studied. So that is a disadvantage of using a Foliage catheter. Now, what is the aftercare that must be given to the patient? Is it must be ensured that the patient is in no discomfort before she leaves after the procedure, and she must be cautioned that there might be mild bleeding per vaginum for 1 to 2 days following the procedure, and for this mild pain, any analgesics may be given to the patient. Now, what are the complications, the pain may occur at the following times. One is by using the falcella forceps. Okay, so during the insertion of the cannula with tubal distension and distension of the uterus. Okay, generalized lower abdominal pain can be present because of the peritoneal irritation, which is caused by the contrast media because of the free intraperitoneal spillage if present by the patent fallopian tubes. Okay, then venous intravasation might happen because if you give extra pressure or excessive pressure while injecting the contrast media, it can cause venous intravasation. Traumatization of endometrium by the tip of the cannula might be happening, and the examination performed when the endometrium is deficient as after curettage or menstruation, that is when the raw areas are present, again it is really bad, and there might be trauma to the uterus due to the cannula causing perforation of the uterus. Okay, and an exacerbation of pelvic infections might be present. Then what is phalloscopy? This is mainly the study of the fallopian tubes, which is a recent development. In this method, a very flexible fiber optic tube is guided through the cervix and uterus into each of the fallopian tubes, thus allowing the visualization of the inner lining of the entire length of the fallopian tube. So this can provide us a useful information about the extent of the tubal damage and the possibility of successful repair. Okay, so this is mainly used for visualization of the inner lining of the entire fallopian tubes, and it also gives us information about the extent of the tubal damage and the possibility of the successful repair. Okay, then talking about the sonosalpingography or the Sion's test. In this, the Foliage catheter is introduced into the uterine cavity with the patient in supine position. The bulb of the catheter is inflated first with normal saline. Okay, then transvaginal TVS of the uterus with catheter in situ is performed in sagittal and coronal planes. After scanning the uterus and ovaries, the area between the corner of the uterus and the ovary on one side is focused. A mixture of normal saline and air is pushed with moderate force into the uterine cavity. That is what saline plus air is pushed into the uterine cavity using a 20 cc syringe fixed to the metallic adapter. If the fallopian tube is patent, the flow can be seen as a gush of fluid cascading past the surprised ovary, and this phenomenon is called a waterfall sign. Then the same procedure is repeated on the other side, which is focused, and this focusing is mainly done in the area of the corner between the uterus and the ovary. Then the same procedure is repeated on the other side. When the tubes are blocked, the patient complains of acute pain in the suprapubic region, and the reflux of fluid and air is seen within the stem of the catheter itself. So there is no waterfall sign in cases of block. Also, uterine cavity can be seen distending in cases of tubal blocks. Now, what is the advantage of the sonosalpingography or Sion's test is that it can demonstrate the tubal block, its site and the extent with high accuracy and reliability. And there is no radiation exposure present because by using a transvaginal sonography, we are going to do this, and there is no X-ray involved, there is no radiation exposure thereby. And disadvantages is the individual tube evaluation becomes difficult sometimes. Thank you.